COPD. And usually smoking is calculated in pack years. That is the number of packs per day smoked times the number of years the person has smoked. So a person who has smoked an average of 2 cigarette packs a day for 20 years has a smoking history of 40 pack years. So that's important to understand, just to see how long your patient has been in this state of not being compliant with not smoking. So according to the 2011 guidelines, and I do apologize, they come out, a little bit on a delayed trajectory. A history of more than 40 pack years of smoking is the best single predictor of airflow obstruction. So you want to also see if your patient is able to walk a 6-minute walk test. If they're unable to, that might just show you that they are not oxygenating very well. So treatment of COPD, you want to think about nutritional support. And the reason you want to support your patient nutritionally is we talked about albumin with the healing process. You also want to make sure that they're drinking enough fluids just to help thin the secretions. And they also might benefit from pulmonary rehabilitation. It's never too late to stop smoking. And you also want to make sure that a patient is taking regular peak expiratory flow meter tests, because that will help to improve the patient's functional status and quality of life, preserve optimal lung function, improve symptoms, and prevent recurrence of exacerbations. It also helps us manage the disease and make sure that the corticosteroids that are going to be ordered, such as the Advair, are working appropriately. So to control COPD daily, they're going to be on a low dose inhaled corticosteroid, also known as ICS. It's delivered through a metered dose inhaler. Reliever, they're going to need quick relief. So controllers are used daily. Reliever is for quick relief, so that needs to be something short acting, not the steroids. It's a bronchodilator that is a short acting beta agonist, such as albuterol. They need an anticholinergic inhaler, which can also help open up the airway, such as Atrovent. And with these medications, as you're giving them, you need to understand that sometimes it can result in the sympathetic nervous system responding, and you have an increased heart rate. So just be aware of that. Long-term treatment, they might be on Spiriva, and then they also might be on Respimat, which is newer drug approved by the FDA. But you want to make sure that your patient understands that medications have to be taken regularly. So the ICS is the inhaled corticosteroids given through the metered dose inhaler. And then the SABA, the short-acting beta agonist, such as albuterol. And then LABAR is a long-acting beta agonist, such as Atrovent. And then you want to make sure that your patient understands that compliance with medications is very important. There's an article that was published by one of the drug companies, and basically just talks about the FDA approving Respimat. So you can read that just so you understand that there's different treatments that are coming up to improve the management of COPD. So with any medications, you're going to have side effects. So you want to think about corticosteroids are going to expose your patients to increased infection susceptibility because of the steroid in it. So you want to make sure that when your patient takes the medication, they rinse their mouths after. You want to also think about bronchitis, cough, urinary tract infections, dizziness, rash, diarrhea, back pain, and arthralgia. And this can be very difficult because your patient is basically used to, having a normal quality of life, and as the disease is getting worse, then these medications might make them worse. Then there's some other mucolytic agents that can be used, such as Mucomist or Palmozyme. Palmozyme, if you remember in your cystic fibrosis lecture, is used to help thin secretions. Emergent management of COPD might involve IV or PO corticosteroids, nebulized bronchodilators, antibiotics if there's an infection present, oxygen, and patients might also be on the ventilator. Now, with the ventilator, the doctors use that very judiciously, because if you do remember, your patients with COPD, their drive for breathing is a lack of oxygen. So if you put them on the ventilator for too long, they might become ventilator dependent and become very difficult to extubate. Mucolytic agents are just those agents that will help to break down the mucus. Slide 23 just gives you an image with the different inhalers that are available. And then other things that you can do in concurrence with the medications as a nursing plan of action include chest physiotherapy. So that's chest percussions and vibration at different positions, about 10 breaths each. And then you want to instruct the patient to breathe and cough out secretions so that you're able to suction. If the patient is unable to cough, you can assist the patient by suctioning. Inserted spirometers also help strengthen the lungs and help to expectorate any mucus that might be sitting in the lung space. And then you want to teach your patient not to talk when dyspneic or try eating, because again, when a patient is dyspneic, they're using a lot of energy to breathe. Pursed lip breathing will also prevent air trapping, and then you want to teach them how to slow down their breathing through their nose and out through the mouth, count to 4 to assist with dyspnea. And then positioning, controlled breathing, and relaxation. Tripod positioning might be more comfortable for your patient. So to prevent atelectasis, you want to change your patient's position frequently. You want to encourage early mobilization from bed to chair, followed by early ambulation. This just helps with mobilizing secretions. Use of the incentive spirometer. You want to reinforce appropriate techniques for incentive spirometer use. Take your medications as prescribed, including pain medications and sedatives, judiciously, because you don't want to increase respiratory depression. If you remember, opioids act on the CNS, so your patient's already having difficulty breathing. You don't want to overdo it with the opioids. And then postural drainage is just when you position your patient in a way that you're able to help them drain the secretions that you've helped them to expectorate. And then suction your patient if they're not able to bring up their own secretion. So all your patients should have a COPD action plan. It's based on symptoms, self-monitoring, and reinforcing the usual controller versus rescue, which is the reliever medications. So those are your SABA, LABA, and then your controllers are usually the low-dose corticosteroids, such as Advir. And then you want to also teach them that using the expiratory flow meter is important, just to see how they're doing. And there's a link that you can look at YouTube with that on slide 26. So this is an image from the American Lung Association line. For more information, you can go on their website. And then you want to just take a minute right now and see if you really understood this topic. Subjective, those are what your patient is reporting to you as being their symptoms. So I want you to just take a minute and write 5 of this, because I'll ask you to share with the class when you come in on your first day of lecture. Objective, I want you to also think about what labs your patient that has COPD may need done, and then come up with 3 priority nursing diagnoses and 5 intervention for each of the nursing diagnoses that you have come up with. I want you to think about interdisciplinary referral that this patient might benefit from, pulmonary rehab for those people that are trying to quit smoking, maybe a respiratory therapy, smoking cessation, those type of things. I want you to come up with some examples, and then I need you to come up with some teaching plans. So we are going to have an interactive when you come to class, and we are going to be discussing slide 28. So please pay attention to it and make sure that you have something to share. On the next few slides, I do have some NCLEX type questions.